If you can't tell these diagnoses apart, you're going to miss the questions on the exam. So let's break this down so that you get every question right. First, let's talk about somatic symptom disorder. Somatization refers to the experience of external, distressing physical symptoms that cannot be fully explained by a medical condition. This could be things such as headaches, generalized stomach pain, feelings of fatigue and weakness, but completely negative medical workup. In order to have a somatic symptom disorder, one or more somatic symptoms that are distressing or result in disruption of daily life must be present. A core feature is this excess thoughts, feelings, or behaviors related to the somatization, such as high anxiety or going to a bunch of doctor's visits. People can have somatization without having the somatic symptom disorder. Now, these symptoms must be present for at least 6 months. And the treatment is regularly scheduled visits with a single primary care physician to minimize unnecessary workups. This is frequently asked on exams, and they'll ask if you should refer to a specialist or continue to do workups, and the answer is always no. They need to follow up with the primary care doctor frequently. The best approach when talking to these patients in person is to be empathetic, understanding that they are really experiencing symptoms, even though we can't understand the medical cause of it, in order to try to get this person to go seek mental health, because they tend to be very defensive, like, no, I'm not crazy. These are real symptoms, which they are. But understanding that there is a mental health contributor, a lot of times they will have underlying mental health conditions such as anxiety disorders. They're contributing to these somatic symptoms. An example of somatic symptom disorder will be a 45-year-old patient with chronic nonspecific stomach pain. They had frequent doctor visits and are referred to a GI specialist with extensive negative workup, and they're still convinced something is seriously wrong. That would be an example of somatic symptom disorder. Next, we'll talk about functional neurologic disorder, which used to be known as conversion disorder. Now, physicians use both names interchangeably because they keep changing the name. So functional neurologic disorder is when there are neurological symptoms without medical explanation. There must be at least one symptom of altered voluntary motor or sensory function, such as blindness, paralysis, or seizures, something neurologic. The key diagnostic point is there must be evidence of incompatibility between the symptom and the recognized neurological conditions. So say a person goes completely paralyzed on the right side, from the right side of their face down to the right side of their toes. We know this is not how a stroke would present. So that could be evidence that this is functional neurologic disorder. Belle Indifference is when patients may be surprisingly calm and unconcerned when describing their severe symptoms. This is not the case with everyone that has functional neurologic disorder. It causes distress to a lot of people, but just be aware that that is something that can occur. And the mechanism is the patients convert their psychological distress or conflict into physical neurologic deficits. So it's common for especially younger women that have gone through a lot of childhood trauma to end up developing functional neurologic disorder because all of that stress is presenting physically. Treatment is primarily education about the illness. CBT is always the answer for everything on your exams, and physical therapy also can be used if the symptoms are persistent. An example of this would be a young woman that suddenly develops blindness after witnessing a traumatic car accident. Despite her inabilities to see, she appears surprisingly calm. That'd be the Belle Indifference. And say that she walks towards an object and then avoids it. She may not realize that she's doing it, but that can be a sign that, hey, she's not actually blind. This is a functional neurologic disorder. So next we have illness anxiety disorder, which is a preoccupation with having a serious illness. So these patients will have this ongoing preoccupation with believing that they have an undiagnosed illness, and they will frequently go to the doctor to get it worked up. Somatic presentation. So somatic symptoms are frequently not present. If they are present, it's very, very mild in intensity, and that's what distinguishes illness anxiety disorder from somatic symptom disorder is that they're not actually having physical symptoms that are really going on. It's more of this worry that there's something that's wrong with them rather than actually feeling symptoms. Behavior: the individual performs excessive health-related behaviors such as repeatedly checking their body for signs of illness. The preoccupation must last at least 6 months. So as with somatic symptom disorder, at least 6 months must occur of these symptoms going on. It can't just be a week of being worried that you're sick. It affects men and women equally, with an average age onset between 20 and 30 years old. An example would be a 32-year-old man that consistently Googles his symptoms and checks his body multiple times for lumps, convinced he has hidden cancer despite receiving clean physical exam results. Next, we have factitious disorder versus malingering. So it's important to note that these are different from previous conditions, in that in the previous conditions we discussed, the patients are legit worried about their symptoms. They really want to be fixed from whatever illness they feel that they have. Whereas factitious disorder and malingering, there is secondary gain. The patients are not worried about their illnesses because they know they're not real. Factitious disorder: it's intentional falsification of symptoms to assume the sick role. The motivation is internal and unconscious emotional gain, so they are seeking sympathy and attention from people. There's no external reward present, so they're not going to be trying to get out of jail or get out of work. They're not trying to get drugs. They just want that attention. So a clinical example would be a nurse injecting herself with fecal bacteria to create abscesses and receive medical care. A lot of times, these are healthcare professionals that have the factitious disorder, so be on the lookout for that. Malingering, on the other hand, is intentional reporting of false exaggerated symptoms for personal gain. The motivation is external, so it might be more obvious because you can see like, oh, this person's wanting to sue someone for this, or this person wants drugs, this person's getting out of work, or they're trying to avoid getting arrested by the police. Of note, malingering is not considered a mental illness. A clinical example would be, say, a prisoner complaining of severe back pain solely to obtain opioid medications. Verify these conditions. For more high-yield videos, click on the playlist on the right. Otherwise, good luck on your exam.